Mohamad Mohty. I'm professor of hematology at the Saint Antoine Hospital and University Pierre and Marie Curie in Paris in France. My main interests are stem cell transplantation and multiple myeloma. Over the last few years, we have seen the advent of many novel agents in the field of multiple myeloma. And this was really exciting, great news for patients, because for several decades we've been struggling with simply conventional chemotherapy. Most importantly, the combination of some of these novel agents, when you combine, for example, proteasome inhibitors, IMiDs, and dexamethasone, these kind of combinations are able to induce some very strong and deep responses. So the question here, if you are able to induce a deep response with a combination of novel agents, do you really need stem cell transplantation? However, to make a long story short, this question has been asked through different randomized trials, and what we know today from the IFM 2009 trial, but also other trials, is that actually the best results, the best outcome can be achieved actually by combining the novel agents and autologous stem cell transplantation in myeloma. Of course, this is in relatively young and fit patients who are able to tolerate the procedure. So clearly, I don't believe that the novel agents have negatively impacted stem cell transplantation. It is rather synergistic. Actually, the combination of these tools allowed to further improve myeloma outcome these days. The question is about what misconception do we have with stem cell transplantation. I don't believe we have strong misconception. Of course, stem cell transplantation relies on high-dose chemotherapy. We know very well the side effects of this chemotherapy. They are rather difficult for the patient. It needs a relatively long hospitalization, 2, 3, 4 weeks, depending on the environment. So obviously this can be viewed as rather difficult to the patient compared to receiving a combination of oral drugs in an ambulatory setting. Nevertheless, I think we need to acknowledge that autologous stem cell transplantation is a relatively very safe procedure. Mortality is less than 1% in general. Of course, nausea, mucositis, diarrhea are still a matter of concern to the patient, but there are some tools which can allow to decrease the incidence of these complications. So I would say in general today, in 2017, and based on the data we have seen at this ASH 2017 annual meeting, autologous stem cell transplantation is here to stay in myeloma, at least in a European environment. In general, autologous stem cell transplantation should be considered frontline as a frontline therapy for young and fit newly diagnosed multiple myeloma. This is where we have the strongest level of evidence based on phase 3 randomized trials. So the optimal sequence would include an induction regimen based on the combination of novel agents, usually triplet agent, but maybe now quadruplet, adding monoclonal antibodies will make it in the next couple of years. Then you have stem cell mobilization, collection of the graft, high-dose chemotherapy. What we know today is that melphalan 200 is likely to remain the standard of care. We've seen again during this meeting some results about randomized trial. Unfortunately, when you combine melphalan 200 plus bortezomib versus melphalan alone, there is no difference. So melphalan is still there. There are some interesting results about combining melphalan and IV busulfan versus melphalan. It is a highly effective combination. However, it can generate some added toxicities. So we really need to weigh the pluses and minuses before adopting this kind of heavy combinations as a standard of care. Then you have all the post-transplant continuous therapy, consolidation, and maintenance. But this is really an optimal sequence these days, and in a standard risk multiple myeloma patient who would receive this full treatment package, you would expect many years of progression disease-free survival. And this is really good news because you may also be able to include some periods of treatment-free interval. The transplant activity keeps on growing almost everywhere, and one important aspect that we have seen is the increase of the age limit. Historically, it used to be limited to age 65, but now we have patients who are age up to 70 who can receive it easily. I have even seen in this ASH 2017 meeting a small series of patients above the age of 75, and the procedure is rather safe. So definitely frontline treatment with autotransplant is a standard of care for many patients. Historically, before auto transplant for myeloma, we used to use VAD, vincristine, erythromycin, dexamethasone. We know very well now that this is not anymore an option with the availability of all the novel agents. So an optimal induction regimen these days, in my opinion, and based on the available phase 3 data, available strong evidence, phase 3 randomized trials, should rely on the combination, on the triplet combination of a proteasome inhibitor, namely bortezomib, plus an IMiD, whether it is thalidomide or lenalidomide. It gives you VTD or VRD. Combining bortezomib with an alkylating agent like cyclophosphamide is also a relevant and widely used option. This is the famous VCD or CyBorD regimen. These are the most popular regimens worldwide. Maybe in the near future we will see other combinations replacing bortezomib with a second generation proteasome inhibitor like carfilzomib in combination with IMiD. That would give you KRD, for example, if you combine it with lenalidomide. If you combine it with thalidomide, KTD. Also, there are ongoing trials testing adding a monoclonal antibody like daratumumab to the triplet combination. Daratumumab plus VTD is being tested, has been tested. We are still waiting for the results. But in general, in routine practice, a triplet combination using a proteasome inhibitor, bortezomib plus an IMiD or plus cyclophosphamide is likely to be the standard of care and will remain for many years. The future of autologous stem cell transplantation in myeloma is a recurrent question because whenever you have new agents, easier to use, maybe less toxic, capable of inducing a deep response, you may question whether you need or not autologous stem cell transplantation. In another word, if you have a combination of drugs that is able to induce a very deep response, namely negative MRD, like 10-6 threshold level, you may still ask the question whether I need a transplantation. Today, we do not have the answer to this question. It may prove in the future that those patients who can achieve really such deep MRD negativity, but also long-lasting negative MRD, maybe, especially if they are standard risk myeloma, they may not need to proceed to auto-transplant. So this is really a very attractive scenario. We do not have the evidence to apply it in routine practice today. And this is why, for the moment, the auto-transplant activity in myeloma continue to increase, I think, worldwide.